Turn Teams, an evidence-based practice project by Jennifer Hutton, Jennifer Ryan, and Sarah Jo Schwinn, or the St. Luke's North Night Team. Our PICO question: on medical telemetry and med intermediate at St. Luke's North, would implementing turn teams compared to no turn teams lead to fewer hospital-acquired pressure injuries? We will shorten these as HAPPIES during the presentation. A little background. To reduce pressure injuries, nurses and staff need to turn or reposition patients every 2 hours. That is current St. Luke's policy. Depending on staff members and patient census on the floor, this practice can be difficult to maintain, increasing the time between turns or causing them to be missed completely. Also, in regards to St. Luke's policy, we use the Braden Risk Assessment to give our patients a score for high risk, and anything 15 or less requires turns. Our first article is an individual correlational study. Its purpose is to empower nurses and to use existing resources to reposition high-risk patients every 2 hours to reduce HAPPIES. To do this, assignments are made prior to shift and reviewed at start of shift. Each pair of nurses took one time slot and spent approximately 15 minutes to reposition all high-risk patients on the unit. They charted the repositioning and communicated the intervention with a magnetic turn clock on the patient's door. During times when nursing duties were most intensive, charge nurses and other leaders are scheduled to the turn teams. Staff benefits include engagement, enhanced teamwork, and notable time saved. Patient benefits: by timely care, they're less likely to refuse repositioning, which is what we want, and they are aware of cares as long as the turn team initially communicates what their job is at the start of shift. Happy outcomes include reduced occurrences to single digits or 0 over time. Article 2 is another individual correlational study. Its purpose was to investigate the implications of turn teams. They did this by primary nurses updating charge nurses about turning needs based on the Braden scale, and any score below 18 with an inability to reposition themselves was added to a board. Charge nurses then assign caregivers to time slots and post where the team can see on the board. On the odd hours during the shift, caregivers round, reposition to the opposite side, and then document in Epic. One time slot per set of nurses or nursing aides. The staff benefits included 83% of staff reporting that they found turn teams to be helpful, 81.5% charting compliance, and the unit eventually permanently adopted the cost-neutral intervention. Happy outcomes went from 9 to 5 occurrences to further dropping all the way down to 0 with consistent and effective use. Article 3 is another individual correlational study. It was a poster actually presented at a conference on a unit very similar to our med-tele floor. The purpose was to improve job performance, enhance teamwork, and decrease adverse events related to not repositioning patients every 2 hours. They designed a whiteboard with time slots for every 2 hours and 2 staff members to sign up for each slot. Boards included the rooms with Braden scale scores. Nurses, clinical partners, respiratory therapists, patient care managers, and even supervisors were included in the collaborative team. Staff benefits included total staff participation with the autonomy to choose when they would participate in this initiative during their shift. And happy rates fell to 0. Our recommendations include the implementation of turn teams on floors such as med-tele or med-intermediate, and even med-surgical floors due to positive outcomes seen in all the studies we reviewed. The primary nurses would be responsible for updating the Braden scales at the start of each shift and adding at-risk patients to the turn board that would be created and visible at the nurses' station. All RNs and NAs will sign up in pairs for a time to turn during huddle at start of shift. Staffing numbers will determine how many slot each staff member will take. So on smaller units where there are only 2 to 3 nurses on the entire unit, obviously people will have to sign up multiple times, but there will also be less people to turn. So it's a give or take. Rounding would occur on the even hours, and the turn team for each hour would be responsible for charting the intervention in Epic. Most likely we would recommend that they would do the charting in the room before they leave and go on to the next patient so it doesn't get skipped. And then in addition to using the turn teams, charge nurses will be able to use Volt like we do today, and send messages to remind people when their turns are coming up or if they forgot to chart, and just use it as a way of keeping each other accountable. Here's our references, all of which are from 2018 or newer.